Well, we've heard a lot about the S-CHIP program, and we have a lady patiently waiting over here who's been with us for a while, and that's Mary Sibley. Mary is the Deputy Commissioner of the New Jersey Department of Human Services, and under her areas of responsibility is the Medicaid program, and specifically to further implementation of the S-CHIP. Mary has joined the administration just recently, and previously she has had other positions as the CEO of a Visiting Nurse Association of Staten Island. She was a policy advisor in the Bradley campaign. She worked in the administration of Governor McGreevey, and most recently she was in the policy, heading up the policy department at Roche Pharmaceutical. So join with me in thanking Mary for coming. Mary?
And this is a great segue, Dr. Red Leonard's presentation, because he talked about the whole S-CHIP program and how that's used as a safety net. So I want to talk about what New Jersey's doing. But before that, I do want to mention that I know Dr. Red Leonard's not in the room now, but I saw a presentation that he did about 3 years ago about disaster preparedness. He has a great book about it, and I'll tell you, if you see him speak about that and about how we're not prepared for disasters, he mentioned that briefly, it's very compelling and very scary. So what we do in New Jersey is we have one of the most generous S-CHIP programs, and I'm going to talk about a little bit about the statistics about the program, but more importantly, I want to give you a sort of a sense of the issue of the uninsured, what we're doing to try to cover children, but also the barriers to hold the whole S-CHIP program. Because when politicians try to pass laws and say everyone should have insurance, that's a great thing, and John Corzine just signed a comprehensive children's health bill in July, and we're trying to implement that now, and that is a great thing. But as always, the devil is in the details, and I'm here to tell you some of the roadblocks we've run into in trying to implement the S-CHIP program in New Jersey, and some of the things that we're up against in government, and also what other states are doing as well. So this basically just gives you statistics, and what I want to talk about on this slide is the fact that New Jersey, once we got the S-CHIP money, which was in 1997, people in New Jersey were very enthusiastic, particularly the Department of Human Services. So what they did was they didn't just have S-CHIP, they decided that they were also going to do this family care program for adults as well. So what they did was they enrolled a lot of adults in what they call the general assistance population, which are single adults, the poorest of the poor, and then eventually they also enrolled parents. Then in 2001 and 2002, when I was working for Governor Jim McGreevey, we ran into a budget crisis. Sounds familiar, doesn't it? Another budget crisis. And so what they ended up doing was they actually disenrolled the general assistance population, and then they closed family care to parents. And I'm commenting on this because I think that this is really one of the problems that we're facing, is that you give people insurance and you take it away, then you give it, then you take it away, and you're never going to have a medical home and you're never going to have continuity. So it is a real problem. And we know that in New Jersey, parents really do want insurance. Since we signed this law in July of 2008, which calls for insurance for all kids, we also increased the number of parents who could be on New Jersey's family care. So what we did was we raised the rate to, I think, 200% of poverty, and we have a lot more parents in family care, and that has implications as well. Now, what we have, this is a snapshot of family care and Medicaid today, and what we do in New Jersey is we don't call them something different. We don't say this is Medicaid and this is family care, because we don't want people to think that it's welfare. We, in fact, in all of our websites, we say this is not welfare. And the reason for that is because we want parents to enroll their kids. We want them to get care if they can. So we put it all together and we call it New Jersey Family Care. But you can see at the bottom we have 105,000 adults in our family care S-CHIP program. Now, that's great for us in a way because these are the parents. But one of the things that happens is when you enroll adults in these S-CHIP programs is they're quite expensive. And so that's always a budget pressure that we face. So constantly we're having a dialogue in the state about how many parents to enroll. Also, we've had a lot of back and forth with the federal government about our family care program, because in this particular administration that we've just been going through for the past 8 years, there's a lot of feeling that adults shouldn't get the S-CHIP program, although other states do cover adults. And there's a lot of feeling that only really poor people should get the program. So we've had a lot of back and forth, because New Jersey has the highest income rate for family care S-CHIP. and I think I'm going to show that to you. I don't know if you can read this, but what it really says is that up to 350% of poverty, you can get S-chip. And that means for a family of 4, it's about $74,000 in income, and it only costs you $128 a month for family care. So it's a very generous program. And recently, Governor Corzine went down to Washington, D.C. to defend our program. We get a lot of controversy because we have such a high rate. But the way we talk about our program is that New Jersey, if any of you here live in New Jersey, it's a very expensive state to live in, very expensive, particularly on the housing side. So for a family of 4, $72,000 is not a lot of money in New Jersey. So we've been defending our 350% of poverty for the last couple of years. Now, another barrier that people have to get onto these programs, we face it in New Jersey and other states have as well, is the application process, because it can be onerous. And when we first had our application, it was 15 pages long. And you could imagine trying to get people to fill out a 15-page application every year for their kids. So finally, we streamlined it to 1 page, and I'll show it to you. We now have an online application, so you can go online and apply. And we have reduced the amount of documentation that's required in order for us to match your income. We, again, a lot of government programs, there's always a push and a pull in government programs, because on the one hand, legislators say, you should insure kids, it's really important that kids have insurance. Then the other hand, they say, but we don't want anybody who doesn't deserve it to get this insurance. You got to be really careful. So they did an audit on our family care program, and they found a very small percentage of people, small, maybe under 1%, had actually fudged their income. Maybe not exactly what it was supposed to be, and had actually gotten family care, so they were not deserving of family care. So then what happened is one of the legislators of the legislature decided that that wasn't a good idea. We were going to have to do income matches with taxation to prove that people really deserve to have family care. So we're working with the Department of Taxation right now to actually match people's paycheck stubs to what they say that what they earn. Now, that's the good news and the bad news. The bad news for us was that, we went through this audit and improved that some people were not on appropriately. But the good news was we started working with New Jersey taxation. And we found that that's been a very good source for us for data. And we're currently, right now, doing data matches so that people, instead of having to send in documentation saying, here's my pay stub, that we can actually take their Social Security number and match it with their tax return to determine their eligibility. And this is really important because the more documentation you require, the more paper you have to bring in, the more people have to search for their documentation, and it really, really slows down the process. So other states are trying to do this as well. Also in New Jersey, you'll find next year when you file your taxes, we actually put a question on the tax form that says, if you have a child and you have to put your dependents on your tax form, does your child have insurance? Because we're trying to seek out children who don't have insurance so that we can let them know that we have this new law that's saying you have to have insurance, but also that we can possibly provide it to you. Another thing that New Jersey did, again, a little bit of controversy, was we reduced the period that you had to be uninsured. If all of you have been working with children's health issues, you know there's this issue of crowd out, which is that the federal government and has believed that if you give insurance to kids, they're just going to peel off from the employer-based system and then you're going to jump into a government program. And so what they've had, these long waiting periods, so you have to be uninsured for sometimes up to a year before you're allowed to get on the program. And of course, if your child needs care, uninsurance for a year is not a good solution. So New Jersey, we've reduced it to 3 months. So you only have to be without insurance for 3 months. And if you have an event, for example, you lose your insurance because you lost your job, you don't have to go through the 3-month waiting period. This is our application. I guess it's kind of hard to read. And it's on 1 page, and what they did was they squished all this information, but this is just a demonstration of what it looks like now. Now, since we've been running this program since about 1997, we have done a lot of, obviously, research on our program, and we found that it really does make a difference in our population. We have better prenatal care, we have better screening for kids. But I wanted to mention something that, that both physicians mentioned when they were up here talking, and that is the stress issue. Speaking as a parent, as a single mother myself, having kids, if you don't have insurance for your kids, it's very stressful for you as a parent. It's hard enough to make a living, to go to work, to get your car to work, and then to not have insurance for your kids. And so it's not always just a question of having insurance so they can go to the doctor, but it is a burden on parents when they can't get insurance for their kids. It's a psychological burden. And I think that one of the reasons that we also try to get parents into the program is because it's a burden on them as well. So in New Jersey, we've been really trying to get as many people on these programs as possible so that we can give people coverage so that they can access medical services. And I also wanted to also echo what both physicians said, that with this population, with a Medicaid population and a family care population, there are other barriers than just insurance, and it's absolutely true. I mean, transportation is a significant barrier. Time is a significant barrier. If you're a parent and you have to work all day, when do you have time to go and take your child to the doctor? A lot of people, if they take a day off, they don't get paid at all. So there's a lot of barriers that people in different situations don't understand. So we're very aware of that, and we try to work on some of those issues as well, some of the transportation issues, and our Medicaid program does include transportation. We have seen improved outcomes in the people that we have enrolled. We have better baby outcomes, the births, fewer preterm births. So we're keeping records, and we're trying to demonstrate that having coverage over time is a good thing for children. It's good for health outcomes, and of course, over time, you would expect to see some decrease in costs. Now, the other positive outcomes we found is that if a parent is enrolled in our program and they're getting coverage and they also get to see a physician, it's more likely that they're going to keep their kids on coverage, which is another reason we keep telling the federal government it's important to have parents have access to. We've also found that because we've been doing this Covering Kids initiative, we have spent a lot of time outreaching to other organizations like faith-based organizations. We have a very strong partnership with the FQHCs. We have started a few school-based health centers. We're really trying to get everybody sort of working for the same goal. And we have found that for the most part, people who are enrolled in this program are pretty satisfied. It's a managed care program. We have 5 managed care plans in New Jersey that administer the program. And for the most part, people are pretty satisfied. Now, as I mentioned in the beginning of my presentation, John Corzine signed a new law in July of this year, and it's a law that all children in New Jersey are supposed to have coverage within 1 year of September. I don't know if you're aware of that. How many people have actually heard of this law? Oh, okay, everybody here knows about this. Okay, because one of the challenges we have right now, and this is my job, what I'm working on, is sort of getting people aware that this is a law. So, for example, one thing we did was we sent out letters to all the school districts so they could put letters in the kids' backpacks and send them home and tell the parents that they're supposed to have insurance. Now, we have a lot of challenges, and being in the government, I'm the person who doesn't write the legislation. I'm the person who actually has to implement the legislation, and I can tell you that there's often a lot of difficulties. As I said earlier, the devil is in the details. So first off, one of the things is we have a soft mandate, and that's what a soft mandate is we say you have to have insurance. It's the law. But we don't provide a penalty. There's no tax penalty. And I know that in the last debate, I believe with Obama and McCain kept asking Obama, what's the penalty? Tell me the number, tell me the penalty. I don't believe his plan has a penalty. But we don't have a penalty either. And it's not the same as a Massachusetts plan where there's sort of like a dual penalty, where in the Massachusetts plan, you get a tax, like a tax increase or tax hit if you don't have insurance, and also employers who don't offer insurance have to pay into a pool. So there's like a two-pronged strategy. We don't have that in New Jersey. It's a soft mandate. We have an issue called in-reach versus outreach, and that is, how do you find these uninsured kids? We are trying to do it through data matches, which is not that easy because data is often incomplete, it's often wrong, it's often protected, so you can't get the data. But we try to do that where we try to look at everybody that has a certain, let's say they're in the WIC program. We try to find out if they have insurance. So we do a lot of internal mailings to try to sort of target kids that we think don't have insurance. But the data matching is really a challenge. It's really difficult because there's HIPAA laws, there's FERPA laws, there's privacy issues, and so to actually get real-time data and then be able to reach out to those kids is not always easy. Now, another barrier, which if you're all practicing, you're aware of, is there's language barriers. And there's what I call mail barriers, which is when, let's say we, the Department of Human Services, send you a letter. Many people do not open their mail. They don't open their mail. They let it stack up. I don't know that's a common thing. Or because they're afraid to open it, or they don't want to open it. Sometimes they move a lot, so we don't have the correct address. That's a persistent problem in our Medicaid population, that people are relatively transient. So if you send a letter to a family saying you may be eligible for insurance, they may never open it. Maybe they open it, but they can't read it. Maybe they open it and they can read it, but they don't really understand it because their reading level might be low. So that's obviously an issue for us. The immigrant population is a tremendous issue for the kids. And here's the issue. Obviously there are many kids who are immigrants themselves. They weren't born here, they're not citizens. But more likely, in our population, we have a lot of immigrant parents who may or may not be registered. And we have children who are born here. But the parents are afraid to sign their kids up for insurance because they're afraid that they're going to be deported or they're going to be somehow targeted. And so as much as you might mail things, which is, again, that's not what they want, mail things or talk to them, there's still a lack of trust. They just feel like, I don't want to put things down on a piece of paper for the government because they might find out something about me, particularly if we ask for somebody's social security number. So and I have to say that we're working on this right now as one of our challenges, and I don't really know how we're going to get through this one. And Governor Corzine, he's very firm, he's very insistent that we've got to get all kids covered, and of course that's what we're trying to do, but it's not always going to be easy because, as I said, there's a reluctance. And there's also some people culturally don't have the concept of insurance. They have a concept of maybe I'm going to go to a clinic, but not that I'm going to have insurance. One of the things we have done to try to help this law sort of push it through is we have something called presumptive eligibility, which means that if a child presents at an FQHC or at a hospital emergency room, the emergency room is required, or the FQHC is required to put them into the system, presumptive eligibility, to try to enroll them online, and they must do that, and they cannot bill us for the services. In other words, they cannot bill Medicaid for those services because we're presuming that they're eligible. So they can go online just by an income screen and you'll know if they're eligible or not. And that's just been implemented in the last, not even in the last 4 weeks. And we know already that there are barriers to that as well, because we've heard from the FQHCs and they said, to sit there with a family where there's a language barrier and 2 or 3 kids and to go through your screens and type everything in could take an hour. And we don't have an hour. So that's another issue that we're working on internally. So my job in my current role as a deputy commissioner is to try to figure out how do you sort of smooth the way, how do you make it work, how do you make it easier for people. And another issue is how do you get the word out there. So one of the things we're looking at now is whether or not we're going to do a media campaign, and we're going to try to get kids, so people know that kids have to get insurance. Another thing that we put in place as part of this package is we do have something called Family Care Advantage, which is you can buy into family care, into insurance, for $138 per child, no matter what your income is. So if for some reason you don't have insurance through your employer, for some reason you have a high income, over our 350%, or if you're an immigrant and you're not, or an illegal immigrant even, and you're not allowed to get a Medicaid, you can buy into Family Care Advantage. So that is offered right now through Horizon, the Horizon Blue Cross program, and people can buy into it. We have very low take-up right now. We only have about 150 kids, but we only started it about a month ago. So what John Corzine is trying to do is he's trying to make it almost impossible to walk away from having health care for your kids because he thinks it's so important. And of course, we totally agree it's so important, and we're trying to do everything we can to make it easier and make it happen. But as I said, it's not always that easy. It's not always that easy to get the data. I think this might be my last slide, but I wanted to end with a comment about the whole Washington, D.C. issue, because as we said earlier, there hopefully is going to be some kind of health care reform. And as was mentioned in my introduction, I was the head of public policy for Hoffman LaRoche, which is a pharmaceutical company. And what I did was I spent a lot of time down in Washington over the past 4 years working on pharmaceutical issues. And we had a lot of lobbyists in Washington that we hired because as a pharmaceutical company, very wealthy, sort of lavish, we could hire lobbyists and consultants. Well, who are those people? Lobbyists and consultants in Washington tend to be people who have worked on Capitol Hill. They've actually worked for a committee or for a senator or for a congressman. Those people tend to be very young people, like in their 20s. They tend to be highly educated people, and they all have insurance. They all have insurance because they're part of FEHBP, which is Congress. So when I would talk to our lobbyists and consultants and people that work for us at Roche, they really, really did not understand why the uninsured are a problem. And I mean, they don't understand. They're young, they're healthy, they have money, and all their friends are insured. And everybody that works in that big complex down there called Washington, D.C., and the agencies and Congress, the lobbyists, the lawyers, they all have very good coverage. So they don't understand it. So one of our lobbyists said to me, who has 2 children actually, she said, I don't understand the problem. First of all, I think that, people, it's their own fault if they don't have insurance, and I don't understand the problem, and I don't get the problem. They, as George Bush said, they can just go to the emergency room, or they should just get a better job so they can get insurance. So I said, well, I understand why you don't see I understand why you don't see that that's a problem. I said, but let me put it to you a different way. If your son has an accident or your father has a heart attack, they're going to be rushed to the emergency room. And you know what they're going to find? I used to be an emergency room nurse in Washington, D.C. What they're going to find is the emergency rooms are crowded, they're packed with people, and when you want your father to get in there to be seen, you're going to have to wait, because everybody else who doesn't have insurance is also in the emergency room, because we don't have hospitals for poor people and hospitals for rich people or hospitals for insured or uninsured people. We don't have those yet. And so you may think it doesn't matter. You may think it doesn't matter that you don't have that you have insurance and that person down the road doesn't, and that's their problem. It's going to be your problem when you have an issue and you have to go to to see medical care. So that's my whole speech. I guess I'll take questions. Raise your hand.
Hi, thank you. It's great to hear about the changes in the family care program. I had been the coordinator at the county level, originally when kid care came into being and then family care. And one of the question I have, it's great to see the one-page application. Does that mean if somebody applies online that they can actually submit it and get a determination, or is there still a turnaround time that I remember it was really onerous previously? What is the turnaround time?
Yes, that's a very, very good question. And in fact, you can submit online. There is somewhat of a backlog in certain counties, and that's one of the things we're working on right now, because we don't want to go out there with a big media campaign and say, hey, everybody get family care if we don't have the people to support it. So I'm actually working on that as we speak to try to get more people to process our applications more quickly, because we don't want there to be a backlog.
Hi. Yeah, I'm Dr. Radhakrishnan. I'm a pediatrician here in Trenton, and the biggest complaint we've had is the turnaround time. People saying we've been waiting 6 months, 7 months. We haven't heard anything. We don't know where to go. And secondly, of course, are you also going to be publishing the fact that you have this buy-in program available for people with incomes above what's considered eligible?
So are you asking me about the buy-in program, or just commenting on it? What about the question? What's the question?
Are you going to be publicizing that too? Because we've never heard of it till
today.
Oh,
okay. We're going to publicize it. Yes, we are. Yes, we are going to publicize it. But, I'm so glad you brought that up about the turnaround time, because that is one of my #1 issues now. And I'm actually going to the computer company that does our processing on Monday to take a tour and talk to their managers, because we really cannot have a backlog. We cannot go out there and say this is a great program, it's available, and then not have any, and not be able to turn around those applications.
How many people do you estimate will show up in hospitals as presumptively eligible? And from what you said, that then is not a reimbursable incident to the hospital. How is that going to affect the bottom line of these hospitals? And what happens when the person then goes to another hospital if they're presumptively eligible? Does that hospital also get nailed or not reimbursed, as the case may be?
I'm not sure exactly how the mechanics work, but it's not, if they aren't eligible, then you can bill us, but you have to try to put them in the system. In other words, rather than just putting them up for charity care, you're going to have to try to put them on our system. And they will, and we get temporary eligibility on the spot. And so when they're temporarily eligible for that service, you'll get paid. And we give that.
How many people do you estimate fall into that category?
I honestly don't know. I really don't. But, you know, we have constant ongoing dialogue with the hospitals and the Hospital Association, the FQHCs, and so if that becomes a problem, we are willing, you know, we are ready to work it through. Our mission there was not to stiff the hospitals at all. Our mission is to say, if the person shows up and they are eligible for insurance, let's get them on now and not wait. That's why we're trying to do it.
Hi, Mary. Tim Martin with the Medical Society. How are you?
I know you. Hi.
See if you can guess my question. Does the department anticipate any disruption in its partnership with Horizon Blue Cross Blue Shield associated with the potential conversion to
The
for-profit?
conversion.
Yeah.
That's a really good question. We've been asked that question before. The question was about whether or not we're going to have a disruption because of the Horizon Blue Cross conversion. And I have to tell you, we've had conversations with them on an ongoing, almost daily basis. And our belief is no. Our belief that that's not going to be an issue. You may have heard, because you're in the world of Trenton, that the rates of the managed care companies were low this year, and there was a lot of consternation about that. But we also know that through some changes that Horizon have made, that their profitability, their loss ratio has improved, and they're feeling better about the program, and so we're working very closely with them, and we don't think it's going to have an impact.
One more over here.
I work at a clinic for the poor and uninsured, and it sounds to me like the only provisions for non-documented immigrant children will be that they have to purchase insurance.
Well, that's one of our, yes, I think that's one of our problems, because we cannot get, obviously we cannot provide them something federally. The only other way to do that is through state only or through grants to certain programs, which is, you know, we do give a lot of grant money to FQHCs and different kinds of clinics, but one of our issues is that we're precluded from the federal government by putting undocumented children on SCHIP. Now, they can buy in, but as I said, I know that doesn't sound like a very good option for people.
Your figure of 120-something is monthly or annually?
Monthly, yeah, per child.
When-
We have a couple other questions, but we do have to move on. But Mary, are you going to be around?
Yes,
Can you join our panel first?
sure.
So